So I welcome you all to our neuroanatomy session. This is the Residence Corners module. We are restarting this session after the holy month of Ramadan. We took a break during that month. So this session is arranged by the Department of Neurosurgery, Liaquat National Hospital, and the idea behind this session is to orient neurosurgery residents with 3D neuroanatomy of the brain, which is very important while performing neurosurgery. The topic of our presentation today is cerebellum. The expert panelist today is Dr. Bilal. Dr. Bilal is assistant professor at Lady Reading Hospital. He did his residency from Lady Reading Hospital and then came to Aachen Hospital for his instructorship. He's now working as assistant professor at Lady Reading Hospital, KPK. I welcome you, Dr. Bilal, and joining us on such short notice.
Thank you. Thank you.
So, as I said, the idea is till Dr. Fawaz sort out his audio issue. The idea behind these sessions is so that residents can learn about neuroanatomy, especially 3D neuroanatomy, and taking use of the Roton Atlas. And this is about 15th or 16th lecture in row. Dr. Fawaz, are you ready? Can we start?
Assalamu alaikum, sir.
Alaikum. Make sure your pointer, you can use your pointer, and if you're ready, then you can start.
Sir, can you see my pointer here?
Yes, Fawaz, I can see your point.
Okay, sir. So shall we start, sir?
Ji, please go ahead. We're already late.
So I'm Dr. Fawaz bin Shahab, resident year 4 neurosurgery here at Liaquat National Hospital. Today's session of our neuroanatomy is based on the anatomy of the cerebellum. So we'll be starting briefly with the overview, and then we'll be proceeding forward. So when we talk about the surfaces of the cerebellum, the cortex of the cerebellum is basically divided into three surfaces, and they are based on the structure of the cerebellum that is basically facing the structure of the bony anatomy of the skull. So the cortical surfaces are divided on the basis of the structures they face or along which they may be exposed to make this description more readily applicable to the operative setting. The first surface of the cerebellum, which is the tentorial surface, it faces the tentorium of the cerebellum, and it is one of the surfaces that is retracted in a common approach, the supracerebellar approach. The next surface we talk about is the suboccipital surface, and it is the one which is located below and between the lateral and the sigmoid sinuses, and this is exposed in the suboccipital craniectomy that we commonly do. The third surface that we talk about is the petrosal surface, and this faces towards the posterior surface of the the surface that is retracted to expose the CP angle. So we talked about the three surfaces that are important. The first is the tentorial surface, the second is the suboccipital surface, and the third is the petrosal surface. Now we know that cerebellum has hemispheres and cerebellum has vermis portion. So each of the three surfaces is divided into a vermian portion in the midline and the hemispheric portion laterally. And these surfaces are divided by a major fissure, which is named on the basis of the surface that it divides. Similarly, the hemispheric lobules, which form each of the part of the three surfaces, they actually commonly overlap onto and they form a part of the adjacent surfaces. So one hemispheric lobule contributing to one lobe or one surface of the cerebellum may also contribute to the adjacent surface, which they commonly do. Then the fissures which divide these three cortical surfaces, they are to be distinguished from the fissures which separates the cerebellum and the brainstem. So the fissures ahead of the cerebellum which separate the cerebellum from the brainstem are three. One which separates the cerebellum from the midbrain, the other one that separates it from the pons, and the third one which separates it from the medulla. So these are commonly, they are named as cerebellomesencephalic, cerebellopontine, and cerebellomedullary fissures that we'll also be dealing with. So this is a gross anatomy of the skull base in this portion. We know that this is the posterior fossa, which is formed by the occipital bone. We also has contribution from the temporal bone. This is the petrous part of the temporal bone, and this is the clival portion. And this is the foramen magnum. So here you would have the cerebellum, and the surface that faces this occipital bone would be the suboccipital surface. The surface facing this petrous bone is the petrosal surface, and the surface which cannot be seen or appreciated here, which would be just beneath the tentorium, would be the tentorial surface. So now we'll be dealing with each of the surfaces grossly and in detail. The first surface that we'll be dealing is the tentorial surface. The tentorial surface conforms and faces the lower surface of the tentorium. The anteromedial part of the surface, which is the apex, is formed by the anterior portion of the vermis, and this is actually the highest or the most superior point on the cerebellum. This surface slopes downward from its anteromedial portion to its posterolateral edge. On the tentorial surface, the transition from the vermis to the hemisphere is smooth. There are deep notches, the anterior and the posterior cerebellar incisura, that actually grooves the anterior and the posterior edges of the tentorial surface in the midline. The brainstem fits into the anterior incisura, whereas the falx cerebelli fits into the posterior incisura. Now, these would not be actually very clear until we see it in the diagrammatic representation. So this is a diagrammatic representation showing you the tentorial surface of the cerebellum. We could see that this is the anterior portion and this is the posterior portion. And this is the tentorial surface of the cerebellum that is actually facing towards the tentorium cerebelli. This is the anterior incisura of the cerebellum, which faces towards the brainstem, and this is the posterior incisura in which fits the posterior falx. This is the anterior border. This is the posterior border, and here we could see the angles, two angles on the both the aspects. Now this tentorial surface has a Vermian portion in the midline and the hemispheric portion laterally. So this is the Vermian portion and this is the hemispheric portion. What we could see here that the vermis is formed of three components which are named as culmen, declive and folium. Whereas on the hemispheric surface you have three lobules, the quadrangular lobule, the simple lobule and the superior semilunar lobule. On both the surfaces, these structures, which are culmen, declive, and folium, and their corresponding components, the quadrangular lobule, the simple lobule, and the superior semilunar lobule, they are basically separated by fissures. So this fissure that you see on the hemispheric surface is the first fissure, which is also called the primary fissure, and this is also termed as the tentorial fissure since it is on the tentorial surface of the cerebellum. This primary fissure actually divides the hemisphere tentorial surface into two portions. These are divided into two portions actually. The anterior portion is the quadrangular lobule, whereas the posterior portion is the one which is again divided into two. Excuse me, sir, can you hear me?
Yes, Awaz, we can hear you. Please continue.
Okay. So this anterior, this is actually the quadrangular lobule, whereas posteriorly you have two lobules which are basically divided by another fissure which is called the postclival fissure. So this anterior fissure was the primary fissure. This posterior fissure, which is in the posterior aspect of the cerebellum, is the postclival fissure. And this postclival fissure separates the posterior portion of this tentorial surface into an anterior lobe, which is a simple lobe, and a posteriorly located lobe, which is the superior semilunar lobule. Similarly, there are certain fissures which are called interfolial fissures on this surface, which actually pass on to the petrosal surface also. Similarly, if you see on the anterior aspect, this cerebellar surface is separated from the midbrain portion of the brainstem via another fissure which is called the cerebellomedullary fissure. So these fissures should always be distinguished from the primary fissures of the surfaces of the hemisphere. Now we'll be reading this in text. The Vermean subdivisions of this surface are superior to their corresponding hemisphere, which is based on the anatomical representation here. The culmen and the quadrangular lobule correspond to the anterior part of the tentorial surface, as we already studied, whereas the declive simple lobule, the part of the superior semilunar lobule, corresponds to the posterior part of the tentorial surface, which are posterior to this primary or the tentorial fissure. We already discussed this, that the fissure separating the tentorial surface into anterior and posterior parts is referred to as the tentorial edge. This separates the hemispheric surface between the quadrangular lobule and the simple lobule, and the vermis between the declive and the culmen. The post-clival fissure separates the posterior part into two, the simple lobule anteriorly and the superior semilunar lobule posteriorly. There are interfolial fissures on the surface which pass anterolaterally from the midline, and they are continuous with the fissures on the superior half of the petrosal surface. So this is a fissure that is continuous onto the other surface. The anterior part of the superior surface of the cerebellum surrounds the posterior half of the midbrain that we have already seen to form the cerebello-mesencephalic fissure. Now, there are certain important aspects regarding the borders of this surface. When we see the anterior border, which separates the tentorial and the petrosal surface, it has a lateral part, which is also called the anterolateral margin. And this is parallel to the superior petrosal sinus, and it separates the hemispheric part of the tentorial and the petrosal surface. And you also have a medial part, which is called the anteromedial margin, that traces the midbrain and forms the posterior border of the fissure between midbrain and cerebellum. So if we see it diagrammatically, this border is that we are talking about. This has an anteromedial edge and an anterolateral edge, and this is its junction. This anterolateral edge is parallel to the superior petrosal sinus, whereas this anteromedial edge is the one that forms the lip of this cerebello-mesencephalic fissure.
But there's a lot of disturbance. Can you take care of that in your voice? Maybe it's your headphones, whatever you're using.
Hello, sir, is it better now?
Your voice is better, but yeah, it's better now. But there, there previously there was some disturbance in between. So continue now.
Okay, sir. So next that we were talking about, we saw the anterior border, and then there is an anterior angle. So the anterior angle is formed by the junction of the anterolateral and the anteromedial margins of this, and this is directed anteriorly above the origin of the posterior root of the trigeminal nerve. So this is also an important entity here. Then we also have a posterior border that we'll be seeing diagrammatically. It is between the tentorial and the suboccipital surface. The lateral part is parallel and adjacent to the lateral sinus, and it separates the hemispheric part of the suboccipital lobe and the tentorial surfaces. Whereas a short medial part, it faces the posterior incisura and separates the vermic part of the two surfaces. The lateral angle is the one which is formed by the junction of the anterolateral and the posterolateral margins, and it is at the location of the junction of the sigmoid, lateral, and the superior petrosal sinus. And here veins often converge. So what is important here is that this is the anterior border with its anterolateral edge, which is parallel to the superior petrosal sinus. And this is the posterior border, which again has a posterolateral edge and a posteromedial edge. The posteromedial edge is facing towards the vermis, whereas the posterolateral edge is parallel to the lateral or the lateral sinus. So here it is the lateral or the transverse sinus. Here you have the sigmoid and the petrosal sinus. So this lateral angle is often the point of convergence of these angles. So this is an important point for anatomical purpose. Now this surface, the tentorial surface, has its relation to an important fissure, which is the cerebello-mesencephalic fissure. So now we will be discussing in detail the deep dissection of this tentorial surface along with the anatomy of the cerebello-mesencephalic fissure. So as we already saw, this is the tentorial surface. The upper part of the tentorial surface actually surrounds the posterior half of the midbrain, and this forms the posterior lip of the cerebellomedullary or mesencephalic fissure. Cerebellomesencephalic, basically between the cerebellum and the midbrain. This is the anterior cerebellar incisura, and this is actually like a notch where your brainstem fits into the anterior part of the tentorial surface. Whereas the posterior cerebellar incisura, which is located posteriorly, this is actually a notch where the falx cerebelli fits into the cerebellum. Here you can see the pineal gland, and these are your sinuses, the lateral or the transverse sinus continuing into the sigmoid sinus. Now this is a further detailed or a deeper dissection. You could see that the midline structures which were contributed by the Vermian portion of the cerebellum on the tentorial surface are comprised of the culmen, followed by declive and the folium. Here you could only see the anterior aspect of this dissection, so we could only see the culmen, and laterally you could see the quadrangular lobule. This fissure, which is separating the tentorial surface into an anteriorly located quadrangular lobule and posteriorly located simple and superior semilunar lobule, is actually the tentorial or the primary surface, which is also continuing on to the vermis, dividing the culmen anteriorly and posteriorly located structures on the vermis, the declive, and the folium. You could also see in this diagram the superficial part of the posterior lip. This is the posterior lip, which is formed by the culmen in the midline and the quadrangular lobule laterally. And here you could see that this is the quadrigeminal cistern, which extends caudally from the pineal gland into the cerebellomesencephalic fissure. Here you could see the laterally located structures. This is the pulvinar of the thalamus, and here this is the third ventricle. These are the superior and the inferior colliculi of the midbrain, which are actually the projections that defines the midbrain. If we go on further, now the culmen has been removed here. So you could actually see the central lobule and its wings, which are actually on the other surface that we'll be dealing ahead. They also form the part of the posterior lip of the cerebellomesencephalic fissure, which is between the cerebellum and the midbrain. A further deeper dissection, when you have further removed the deeper structures, the central lobule and its wings, the lingula and the superior medullary velum, and the medial part of the superior cerebellar peduncles have been removed. So now removing all these structures exposes the further deeper dissection of the fourth ventricle. Now here we could see that this is the fourth ventricle. The lower half of the roof is formed in the midline by this structure, which is called the nodule of the cerebellum, and laterally by the inferior medullary velum. So this is the nodule, and laterally you have the inferior medullary velum, which passes laterally above, but it is separated from the rostral pole of the tonsils by the cerebellomedullary fissure. So this is actually the cavity of the fourth ventricle. This is its floor and this is its roof. The floor has a prominent sulcus, which is called the median sulcus, that we already discussed when we were dealing with the anatomy of the fourth ventricle. And this is the roof, which is formed in the midline by the nodule and laterally by the inferior medullary velum. The inferior medullary velum is actually a thin white matter sheet that separates the tonsils ahead. Here you have the middle peduncle. Above that, you would have the superior, and below that, you would have the inferior peduncle, which are actually connections of the brainstem to the cerebellum. Now here in this figure, some of the middle peduncle has also been removed. So this exposes the lateral anatomy of this region. When the middle peduncle has been removed, this exposes the choroid plexus extending through the lateral recess. Now this is the choroid plexus, which is extending through the lateral recess of the cavity of the fourth ventricle, and it is hanging down into the CP angle, just below the facial and the vestibulocochlear nerves that are located over here. A further deeper dissection of the same space. This is the oblique view of the lower half of the roof, which is formed by the inferior medullary velum and the tela choroidea and the choroid plexus. The inferior medullary velum, as we already saw, it arises on the nodule and then it extends laterally. And then it blends with the floccular lobe of the cerebellum, and this is an important landmark of the flocculonodular lobe of the cerebellum. So these were the deeper dissections of this surface, the tentorial surface, along with the anatomy of the cerebello-mesencephalic fissure. Now we'll proceed on to the other surface of the cerebellum, which is the suboccipital surface. Talking about the suboccipital surface, this is the surface which actually faces towards the suboccipital surface of the skull base. Again, this is comprised of the midline structures, which includes the Vermean portions of the folium, tuber, pyramid, followed by uvula. And again, these has hemispheric portions, which includes the superior semilunar lobule, the inferior semilunar lobule, the biventral lobules, and the tonsils. Again, these has important fissures. Now, this is an important fissure that you can see on this surface. This is the suboccipital fissure, which is dividing the suboccipital surface into an upper and an inferior portion. And you have also a fissure which is continuing from the petrosal surface, which is called the petrosal fissure. So the structures that are important here are, in the midline, you have folium, followed by tuber, followed by pyramid, and then you have uvula, and then you have tonsils, which are actually considered separate structures, and we'll be dealing with them separately. The lobules on the hemispheric surface that are included in the suboccipital surface are the superior semilunar lobule, inferior semilunar lobule, the biventral lobule. So this suboccipital surface is actually located between and below the lateral and the sigmoid sinuses, and it is most complex of the three surfaces. It has a deep vertical depression, that is the posterior cerebellar incisura, which we already saw. It contains a fold of the dura, which is the falx cerebelli. The vermis is folded over and it forms the cortical surface within this incisura. The lateral walls of the incisura are formed by the medial aspects of the hemisphere, as it's very clear diagrammatically, and there are deep clefts which are called the vermo-hemispheric fissures. They separate the vermis from the hemisphere on this surface. The Vermean surface has a diamond shape. The upper half of the diamond-shaped structure has a pyramidal shape, and it's called the pyramid. The folium and tuber superior to the pyramid forms the apex of the suboccipital part of the vermis. Whereas the lower half of the diamond, the uvula, it projects downward between the two tonsils. The rostromedial margin of the tonsils bordering the tapering edges of the uvula. The nodule is the lowermost subdivision of the vermis, and it is hidden. Presentation now.
Dr. Fawaz is
Sirs, here there is some interruption with the system. It's just opening again. We'll be dealing with the service. Okay, so as we were dealing with the suboccipital surface, here we could see.
Can you go to full screen, please?
Yes, sir, I have done it.
And you have got a lot of text, so I suggest that stick to the diagrams if you can.
Okay, sir.
Some internet problem, or what is there some internet problem connection?
So there is some connection problem. Yes.
Yeah.
Okay, so
Yeah, we can.
Can you see this, sir?
Yes, we can.
Yes.
Continue.
Okay. Okay, so we have the following parts within the vermis. If we see this, this is the folium. This is actually a pyramidal shaped structure within the center of the suboccipital surface. These include the upper one, that is the folium, followed by tuber. Then we have pyramid, and then we have uvula. Uvula is actually a thin uvula-like structure within the palate. This extends downward between the two tonsils. These comprises the vermian portion on the suboccipital surface. Then as you see laterally, you have this hemispheric portion accounting for the suboccipital surface. This includes the superior semilunar lobule that we already saw on the tentorial surface. Here it is extending down from the tentorial surface onto the suboccipital surface. This is followed by an inferior semilunar lobule, followed by a biventral lobule, and then you have this tonsils which are located medially on this structure. So you have these fissures. This is the primary fissure, which is the petrosal fissure. And this is another fissure on this surface, which is the suboccipital fissure. Here, if you see anteriorly between the cerebellum and the brainstem, you have an important fissure, which is the cerebellomedullary fissure. So this we already saw. There are deep clefts, the vermohemispheric fissures that separate the vermis from the hemisphere. And then we have these structures. In order to learn their names, we have correspondence between the vermian and the hemispheric portion. So the hemispheric portion of the suboccipital surfaces are formed by the superior, inferior semilunar lobules, followed by the biventral lobules, and then you have the tonsils that we saw in the diagram. Whereas the vermian portions are comprised of the folium, tuber, pyramid, and uvula. So the vermian and their corresponding hemispheric portions from above to below include folium, which corresponds to the superior semilunar lobule, tuber, which corresponds to the inferior semilunar lobule, the pyramid, which corresponds to the biventral lobule, and then you have the uvula corresponding to the tonsils. Now, these are the important fissures, the pre-biventral and the pre-pyramidal fissures. They are actually named on the basis of the lobules they are separating, and they divide the suboccipital surface into superior and inferior parts. Whereas the petrosal or the horizontal fissure that is most prominent on the surface, it extends onto the suboccipital surface and it divides the superior half of the suboccipital surface between the superior and inferior semilunar lobule. Whereas the cerebellomedullary fissure is the one that extends superiorly between the cerebellum and the medulla. So this is the petrosal fissure that is extending onto the surface from the petrous surface. This is the suboccipital or the primary fissure that is separating it into the upper and a lower portion. And this here that you could see is this is the suboccipital surface clearly. This is tonsil again. This is the superior semilunar lobule, followed by inferior semilunar lobule. This fissure is the pre-biventral fissure, and inferior to it would be your biventral lobule. Now, regarding the deep dissections of this surface, whenever you dissect the suboccipital surface, for example, in a suboccipital craniectomy, the deeper structures that we'll be seeing will be seen in the following diagrams, and we have also the relation of the cerebellomedullary fissure to this. So this is the suboccipital surface that is located below and between the lateral and the sigmoid sinus, and it is the surface that is actually exposed in a wide suboccipital craniectomy. The vermis sits in a depression, which is the posterior cerebellar incisura between the two hemispheres. The cerebellomedullary fissure extends superiorly between the cerebellum and the medulla along the inferior half of the ventricular roof that we'll be seeing later on. This is actually the cerebellomedullary fissure. Now, this space or a cleft that you could see between the two tonsils is the vallecula. This vallecula is actually between the two tonsils, and it communicates via the midline structure, the foramen of Magendie, with the cavity of the fourth ventricle. The major vascular supply to this suboccipital surface is via the posterior inferior cerebellar artery that we can see here. So this is the suboccipital surface. These are the sinuses. This is the cerebellomedullary fissure. And here you could see that this is the vallecula, which is extending into the cavity of fourth ventricle via the foramen of Magendie. Here you are, this diagram is basically showing the lower part of the vermis behind the ventricles. This is the pyramid and the uvula that we already saw, the midline structures: folium, tuber, pyramid, uvula. This is the tonsil, and this was the vallecula. So now this has been dissected further deeper. You are extending via the foramen of Magendie into the fourth ventricle. In this diagram, now they have removed this side of the tonsil. The right tonsil has been further removed, and this exposes the lower part of the roof of the fourth ventricle, which is formed by the inferior medullary vellum and the tela choroidea. In the midline, you would have the nodule on which this inferior medullary vellum arises, and the nodule on which the vellum arises is hidden in front of the uvula, here somewhat. Whereas the uvula hangs downward between the two tonsils. The choroid plexus that we could see here, this is arising on the inferior surface, inner surface of the tela choroidea, and it extends through the lateral extension of the cavity of fourth ventricle, that is through the foramen of Luschka into the lateral recesses. And this is behind the glossopharyngeal nerve. Here we could also see these cranial nerves, 9th till 11th. This is the inferior medullary vellum, which arises on the surface of nodule, and it drapes across the superior pole of the tonsil. Now from here, the tonsil has been retracted. So this inferior medullary vellum is ahead of the tonsils, and it is draping across the superior pole of the tonsil, and then it blends with the floccular lobe of the cerebellum. So this forms the classical flocculonodular lobe of the cerebellum. Now in this deeper dissection, both the tonsils have been removed. This exposes the inferior medullary vellum even more clearly on both the sides. This is a thin sheet of the inferior medullary vellum that is arising on the nodule, which is ahead of the uvula, and then it is extending laterally, and then it blends with the floccular lobe of the cerebellum. The telovelar junction is actually the junction between the inferior medullary vellum and the tela choroidea. So this is the tela choroidea here, and this is the inferior medullary vellum. In between these two is the telovelar junction, through which we approach via the telovelar approach to the different tumors. This structure, which is the rhomboid lip, is a sheet-like layer of a neural tissue which is attached to the lateral margin of the ventricular floor, which extends posteriorly to the glossopharyngeal and the vagus nerve. So these structures are actually important with reference to the cranial nerves. Here you have the exit to the cranial nerves. And this also forms a pouch at the outer extremity of the lateral recess. Now this is the cavity of the fourth ventricle. This is extending laterally through the lateral recess. This is the midline structure, the foramen of Magendie, through which you would enter the fourth ventricle. In this diagram, the right half of the tila choroidea has been removed further. This exposes the ventricle and the lateral recess. The inferior medullary vellum, which is this structure, extends laterally to form a peduncle, which is also called sometimes the peduncle of flocculus. And then we have already seen that this inferior medullary vellum, which arises on the nodule, this extends laterally and blends with the flocculus at the region of the lateral recess. So here you have this lateral recesses. This is the pedicle of flocculus. Again, the extension or a further deeper dissection or a different view of this diagram, the lateral view of the upper half of the ventricles is formed by the superior cerebellar peduncles. Here you would have the superior cerebellar peduncles, the two. The inferior cerebellar peduncles ascend along the dorsolateral medulla and form the anterior and rostral margins of the lateral recesses. Sir, shall we continue with the petrosal surface or do it in the next time? Because we are left with the petrosal surface followed by the
Hello.
tonsillar anatomy.
Yes,
Hello.
Dr. Bilal. Dr. Bilal, yes, you want to?
Yeah, you can briefly just give an overview of the petrosal surface because it is the most important surface we usually do is in the CP angle we usually do it. So you just give a briefly overview of it, very brief, just major
Okay,
overview.
actually, then we also have a presentation followed by these in later sessions on the CP angle anatomy. So we'll also be dealing with that.
Okay, you just give a brief overview. It's
Okay,
not
sir.
very
Okay.
detailed. Okay.
Okay, sir. So this is actually the petrosal surface. This is the surface that faces towards the petrous part of the temporal bone. Again, if we see here, this is the superior semilunar lobule. This is the primary fissure of this petrosal surface, which is also called the horizontal fissure or the petrosal fissure. And then you have inferiorly between this horizontal fissures, you have two lobules, the inferior semilunar lobule and the biventral lobule. So actually these lobules are extensions from the suboccipital surface that are facing also towards the petrosal or also contributing towards the petrosal surface. So this is the quadrangular lobule followed by semilunar lobule, followed by inferior semilunar lobule, and followed by biventral lobule. This surface has an important fissure which is called the horizontal fissure, and this horizontal fissure actually continues as a V-shaped structure into the superior and the inferior limb of the petrosal cerebello-pontine fissure. So this actually continues on to the pons, and these are the superior and the inferior limbs of the cerebello-pontine fissure. And here we have important cranial nerves exiting out. So the median or the vermian portion has a deep longitudinal furrow, which is the anterior incisura that we already studied. This faces the brainstem structure. The right and the left halves of the petrosal surface are not actually connected side to side because you have the ventricular cavity here. The vermal components which are rostral to the fourth ventricle are the lingula, the central lobule, and the culmen, and those which are caudal to the fourth ventricle are the nodule and the uvula. We have already studied nodule and the uvula. The lingula and the central lobule will be revealed in the dissections that we'll see further. The hemispheric surfaces are comprised of the wings of the central lobule, anterior.
Kindly skip this.
Okay, sir.
This all is okay.
Okay,
So you
sir.
just give an overview on the diagram. That would be more beneficial and more.
Okay, sir. So these are the diagrammatic representations of this petrosal surface. We are seeing that this is the petrosal surface of the cerebellum that is actually facing towards the brainstem, particularly the pontine portion. This is the horizontal fissure, which is also called the petrosal fissure. And then you have the superior and the inferior limbs of this as an extension of this fissure, which are actually the superior and the inferior limbs of the cerebello-pontine fissure. So this cerebello-pontine fissure is an important landmark in the anatomy of the CP angle. And here you could see that the cranial nerves exit from this fissure. If we see from superior aspect to the inferior aspect, you have cranial nerve 5 followed by 6, and then you have 9th and 12th cranial nerves exiting from this cerebello-pontine fissure. So this is again a further deeper dissection. You have the cerebello-pontine fissure. and you have cranial nerve 5 exiting through it, followed by 7, followed by 8. These all cranial nerves we will be dealing with when we'll be discussing with the anatomy of the CP angle.
Dr. Fawaz, do you have more diagrams to discuss?
Sir, I had a few diagrams, but the system is again doing some errors.
Okay, Dr. Saad.
Yeah.
Hello.
Ji
I
Dr.
think we
Bilal.
had enough of the anatomy, and if you allow me, I think I will just give a brief of operative anatomy. I think Dr. Has sorry, no, Dr. Maz has very beautifully discussed this, and I think it's a very beautiful diagram. And this is the most important that you need to discuss and know, and the resident should know about it. And we will
Fawaz,
be
can you,
discussing.
Dr. Fawaz, can you stop screen sharing and maybe Dr. Bilal can show
No,
his operative?
he should just give these 2, 3, or 4 diagrams, and then you can see it. Yeah, the tonsil there exposed. Kindly do the next diagram, please.
Yes, sir, sure.
And this is, I think, the uvula. This is you said, no? Wormus, uvula. Yes, it's uvula. So these are important that you will be coming across in dissection of the most of the posterior tumors, and it is very important. If you don't even know in the rest of anatomy in that detail, it's not that important. But knowing this anatomy is very much fair. Then important relationships of the arteries in the veins, they are very important in this area. Kindly do the skip to the next diagram.
So
Yeah,
this is again
this is
uvula, but
again
through a
yeah, you have retracted one tonsil, and now it is the uvula and this tila choroidea, and this yes. So this is again, I think, the tila choroidea, which is overlying the fourth ventricle, inferior medial velum, and this is in the midline. You can see the foramen of Mergendi. Kindly skip to the next. This is foramen of Mergendi, and this is the inferior medullary velum, which connects, which is like forms a part of the lower part of the, I think, roof of the fourth ventricle. And yes, again, inferior medullary velum, the same. Can you skip to the next?
okay, sir.
And yeah, this was the tila choroida. I think it was the same tila choroida that we were confusing with the inferior medullary velum.
So they have actually labeled it like this, that this is the inferior medullary
Yeah,
velum
this
and
is,
this is the
but
tila choroidea.
this
So
is a
this is the
telochoroidea.
telovelar
So what
junction.
is basically a telochoroidea? Telochoroidea is basically what, like, it's a membrane bilayer type of thing, pia mater and ependymal cells. So they are telochoroidea, and I think they are also found in the fourth, in the later and third ventricle, telochoroidea. They and in the hair and vessels and veins, they run through it. If you get a next diagram, please skip to that. Okay, so this is arterial anatomy, and this is part of the pica. I think it's you can see it's the pica, and which is branches, and this is the foramen of Magendie, the uvula. It is the uvula, and this is the cerebral peduncle in inferior cerebral peduncle, which connects medulla to the uh, uh, cerebellum, and this is the floor of one ventricle. So I think you have very beautifully elaborated the anatomy, and if you can kindly give me Dr. Saad.
Dr. Fawaz, can you stop screen sharing and maybe Dr. Bilal, due to shortage of time, can share a video only and not the
Okay, sir.
scans. Stop
No,
sharing and talk.
I will just only just scan share a video or
Okay, Dr.
two.
Bilal.
Or okay, thank you.
Can you start screen sharing, Dr. Bilal?
Yeah, I just I just want to. Okay. Now here you can see a cerebellar suboccipital surface very beautifully depicted by this your present. Sorry, I forgot your name, but it was not actually for the. There was some tumor here. We were actually going for a supracerebellar approach, but we were doing this dissection just to relieve some CSF. It was a small lesion, but it was located deep in the culmen in the most anterior medial portion that you said that was in the quadrigeminal system. We will show the dissection, but first of all, I would like to know that so far you have very detailed and beautifully elaborated the fissures and the occipital surfaces. This is the wormus in the midline, and we are just opening this arachnoid, and you can see that all the cerebellar surfaces, they are outside the arachnoid, but you can only see, we will be dissecting, when we open the arachnoid matter, it is actually the cisterna magna that we are opening. So this the pyramids, they are inside, and inside you can see branches of the posterior inferior cerebellar arteries. We are separating, and now we are just, if we are going inside into, we are opening the foramen of Magendie, and we are accessing the fourth ventricle. So there is some rotation problem with the this video, like its orientation. So these are the cerebellar tonsils, and the most important operation that you come across and you want to have a detailed anatomy of the cerebellar tonsil is like a kind of when you have carry malformation. So you have to open the dura. The cerebellar tonsil, they have got very much like these arachnoid adhesions. They are very thick here, and you have to be very careful dissect it, because when you dissecting it, here lies the pica, and there are many chances of injury. So you do it under high magnification and under careful dissection. You do this. So from here you can see like the important structure in here. This is the midline, the wormus, their cerebellar surfaces that Dr. Moaz has very beautifully elaborated. And here we have opened the arachnoid, and we are like dissecting the cerebellar tonsil, not dissecting just to get a CSF flush out. And here is the branches of the pica, and we are entering the foramen of Magendie through fourth ventricle. And the anatomy in this way is a normal anatomy, and we can see the uvula and inferior medullary velum and others. I would like to see another another video with you. Okay. So I would like to cerebellar apex tumor. Here I would just give you an overview of the cerebellar apex tumor. In this, we were doing a tumor that was in the deep down into the cerebellar apex. The most important thing that you go for this tentorial surface is that it is very attached to the cerebellar veins, and if you can see through these bridging veins, it is attached to this surface, tentorial surface, tentorium, and you have to take extra care of these. If these veins rupture, then they bleed a lot. So we have to very carefully retract it. And now this here you can see this is the most anterior middle part, and the tumor was here somewhere, and like here, and we removed it, we biopsied it, and this is the tentorial surface. So it's very good that you know all the detailed anatomy, but from such a point of view, the important thing is that you have to retract cerebellum very closely, very nicely. Otherwise, like we have populated, you can see this population here, we have populated the bridging veins, and sometimes the angle is here, you can see the dark tumor here, the dirty looking tumor here. So the important thing is like retracting cerebellum, so you don't tear the veins. If the veins tear, they will you can stop the bleeding, but at times there is like they are connected to the sinuses and major veins in the tentorium. Excuse me, I've just there's some noise from someone. So to avoid that, you have to very gently retract and very gently you have to.
Are you showing a video? Because the video isn't playing if you're playing one. I'm just saying, asking. Do you want?
Yeah, I'm showing the video. Is it? Yeah,
No,
is
no,
it
it's
not
not.
shared?
No, yes, not showing. The video is not playing.
I don't know why it is, but I have.
Can you play
I
again?
I let me show. I think it is.
Now
Okay,
you started. Now we can see it now. We can see it now. Can
you
you?
can see it.
Yeah, we can see
Okay,
it now.
I'm just repeating. I'm just repeating it. Whenever you have this issue of video, so kindly tell me. I was just sharing another very briefly 2 or 3 videos just to give an overview. My point was that it's good that you know the anatomy in detail. It's very because it helps you a lot. But you can see you can't appreciate any fissure, any column here. And the most important thing for neurosurgical point of view, for neurosurgical reason, for neurosurgeon is the bridging veins, that you have got the bridging veins over here, the tentorial surface. And when you retract the tentorial surface for the access to the pineal gland tumor or some supracerebellar approach to tumor of the cerebellum or some other in the in this area, then you have to coagulate these veins very carefully. You can see this my pointer. You can see like this. There's some coagulation here, and we have retracted the cerebellum, and now we are going deep into the tumor. And the angle that is important, as you say, because it's slope upward, so you have to very carefully retract it so you don't injure the these veins. I will just share a few videos if you don't mind, uh, and
So
that
we just
is
have. We're just at the end of the session. If you can just share one more video and then we can
okay. I
continue.
will just share one more video. So it is just related to the cerebellum, but it is more of a, cerebellar anatomy. Can you see it?
No, it's not started yet. Can you? I'll tell you when it starts.
Is
No, sir. We can see your
just started?
screen.
Yes, video.
No,
Can you see the video?
no, sir. No, sir. No, no, we can't see the video, but we can see the screen where you have 5 videos. So can you close again and maybe restart?
Okay, I have just stopped sharing and I'll
And
just
now,
go for an
yeah,
edit.
yeah.
Okay,
Share again.
can you see it?
Um, let us. I can. We can see your screen, but the video hasn't started yet.
Uh, you tell me if it's
Has it started at your end?
yes, it is started. Uh, so
No. Maybe
let me
try one.
try it again. Okay, let me try it one.
I think there's a lag between the internet. That it
Yes,
takes
yes,
time.
I think takes time. Takes. Tell me if you can see it, the screen.
We can see your screen. And can you restart the video?
Hello. Can
We
you
can
see?
see I can see your screen where there's 5 videos on that, but the video
Oh,
hasn't
the
started.
video hasn't started. The video hasn't
No,
started.
no, sir.
Okay, we will wait for some just a few seconds if it starts. Now you can see or not the video.
Not yet. We're still on that screen with the first 5 icon of the videos. It's not
Okay,
started.
just let
So, Dr. Fawaz, are we going to continue cerebellum next week as well? Dr. Fawaz?
Hello, sir.
Fawaz, are we going to do cerebellum next week as well?
Sir, we
Are we?
only had a slide or two remaining regarding the tonsillar anatomy. Rest we have done.
Okay. Dr. Bilal, we can't see the video. I think due to shortage of.
just one last time. If you can see it, it's okay. Otherwise, we have to. Can you see it?
Yes, we can see the video, Dr. Bilal.
Okay, okay. So this is a tumor. It was a tumor for like the short, just short. Can you see this? So my pointer here.
Yes, we can see your pointer.
Okay, so this was just a dissection, vascular dissection. This is like a major vein, midline vein, and it's like in the this is the cerebellum. This is the inferior cerebellar peduncle, and it's connects to the medulla. And there is a major vein, and we are having dissecting the tumor of the the vessels. So this is the fourth ventricle. And now you can see for approach to tilovelar approach, you have to do this dissection. Like here, my pointer is, you can see branches of like pica here. And so you have to do all this aragonite dissection. Like you can see these aragonite, and you can see that this is very deeply we are exposing this inferior cerebellar peduncle, and we have to do this aragonite dissection, separate this vessel from and these arachnoids from the tumor. And here is the fourth ventricle, which lateral and posterolateral surface is formed by the means in inferior cerebellar peduncle. So I will just briefly go through the video, and we are just dissecting the tumor of the for this vessel of the, and we can now here you can see this is the fourth ventricle, inferior portion of the fourth ventricle, and I can show you if I had this video, I will show you like if oh no, this is not the video. Let me. So it is all this video is about dissecting in the cerebromedullary fissure. There, Dr. Fawaz has depicted, and this is the cerebellum. This is here you can see inferior cerebellar peduncle. If I can show you now, this is inferior cerebellar peduncle. This is a major vein, and these are branches of the pica that is supplying the spinal cord. So we dissected these branches of the tumor, and we did this arachnoid dissection, and we preserved the vein. And here you can see a major vessel, like here, this is most likely the pica, which is giving out its branches. This is cerebellum, the inferior portion of the cerebellum, and somewhere it's like tonsils. So we have to do all this arachnoid dissection that is important in this area, and to preserve these branches of pica and major vein of the cerebellomedullary fissure. So I think it's enough for. If we have time, I would have shared another video.
Thank you, Dr. Bilal, for first of all accepting the invitation at the 11th hour and coming up with such beautiful videos. Thank you, Dr. Fawaz, for the detailed anatomy. I hope it was useful. We'll see you, Dr. Bilal. Thank you for joining us. We'd like to have you in future as well.
Inshallah. My pleasure.
With this, we conclude our session. We'll be next week. We will be doing the anatomy of cerebellopontine angle, and we'll see you all next week. Take care, everyone. With this, we conclude our session. Thank you. Thank you, Dr. Bilal.
Thank you.